We're going to be talking about the psychiatric interview. My hope in this talk is that you'll gain a deeper appreciation for all the parts of the psychiatric interview, see how it fits into medical interview in general and how it differs from a medical interview, but still how it's similar to a medical interview. And then also specifically to take a look at the mental status exam, as well as some screening questions that are kind of unique to psychiatry in order to find some psychiatric diagnoses. First, I just want to say that I have absolutely no disclosures. You see this happy lady here with lots of money flying around her. This isn't me. Here's some references. These are books that helped me create this presentation. The first is the most important. It's a book called The Psychiatric Interview, 4th edition by Daniel Carlat. He has a podcast called The Carlat Report. He also has a book called The Carlat Report. Both are phenomenal resources, and it would be worth your time definitely to check those out. He's definitely an expert in his field in psychiatry. These are books that you're going to be seeing again, or if you haven't seen, this is your first time or your second time with these, you're going to be seeing these again. This is a handbook of general hospital psychiatry, a good overview of consult psychiatry written by Mass Gen. So often a lot of good medical kind of overlaps with psychiatry in there. Then there's the mental status exam, a fantastic book about the mental status exam and all the parts. Very easy, very accessible, lots of pictures, 80 pages. A couple other references: Psychiatric Care of the Medical Patient, a huge textbook about over 1,000 pages. Again, more consult liaison psychiatry, a little more detailed than the Handbook of General Hospital Psychiatry, the Mass Gen one. Excellent resources, and the Synopsis of Psychiatry. So each of these books has a psychiatric interview portion, which I've read, which I'm kind of combined with this. And then, of course, the psychiatric interview book. It's a 300-page book that's by Carlat that's just on the psychiatric interview, and then the mental status exam. So this is kind of a compilation of these references, and then a couple more that we have later. This is our course description. I'll just skip to the course objectives. The course objective is to review some of the best screening questions during your interview for the most common causes of psychiatric illness. Second, to master the basic components of the psychiatric exam and how each can help contribute to the entire diagnosis. Third, how to frame questions to reduce shame and to get more accurate information from the patient. And fourth, counsel patients regarding their illnesses and to jointly form treatment goals. I think each of these treatment objectives is important, and I'm excited to bring this to you. First, we'll just talk about the psychiatric interview and kind of our first point. I just want to create a structure. And really what I'm trying to show here is that the structure of the psychiatric interview in general is the same as any behavioral professional plan and the same as any general medical documentation. So it's a SOAP note. So it has a subjective part, an objective part, an assessment part, and a plan part. That's SOAP. All medical exams include this. I also think all really therapy plans include this as well. But now this objective is just going to have some different parts. It's going to have a psychiatric ROS. It's going to have more psychiatric history. The objective part's going to be different. It's going to have a mental status exam instead of a regular kind of physical exam, although a physical exam can also be included. The assessment will also be different. In psychiatry, we tend to write paragraphs talking about the pros and cons of certain diagnoses. This also happens in some other medical specialties. But the assessment can range from paragraphs to just kind of simple bullet points. And then the plan, we'll get more into that as we go along and kind of talking with the patients. The nice thing in psychiatry and in mental health in general is that we just have more time to talk with patients. And so there can be a lot more joint formulation and planning involved, which is really nice. This is the first part then. So that SOAP note format is going to form the basic kind of structure of our talk today, and we're going to start with the subjective part. These are all the subjective parts of the psychiatric examination, and you can see that a lot of this is looking similar. So we have a chief complaint, we have an HPI, we have an ROS. It's just now a psychiatric ROS. We'll get into that. medical history, but now we add psychiatric history, current and past medications, past surgical history. And then we have family history, but now we're specifically interested in family psych history. So this is all what we learn in like the first and second year of med school, and this should all be kind of normal. Social history, we have the living situation. Now this is really where um, in the psychiatric interview, you're getting into a lot more nitty gritty than you would in other parts. Usually in medicine, we talk about substances, we talk about maybe what people do, maybe where they're living, um, maybe sexual habits, but by and large, this is all rather, I would say, cursory in other medical specialties. But in psychiatry, because of the biopsychosocial model, the fact that I need to find a biologic cause of illness, which genetics are involved in that, a social cause of illness, what exactly is going on in the person's life, and a and a psychological cause of illness, if they have had a past history, past family history, and what kind of psychological disposition they have, and what they're predisposed to. The social history becomes very important. So let's get into each of these parts. But before we get into each of these parts, there's just one part that I really always like to emphasize, especially when I'm talking with medical students, and that is there is a lot of shame in the mental health field, and this is something that I always try to remind myself of every patient because this is what I do. Um, so a lot of this stuff is very normal to me, and this is not normal to patients, and it's not normal even to other doctors. I was actually in a lecture yesterday with a doctor, and he was a family medicine doctor, and there was a patient that he said was quite suicidal, and he did a fantastic job organizing how to get the patient to the ER and organizing social support and things like that. And he said that this was an entirely new experience to him. And that was very interesting to hear on my end because it was surprising only because I was surprised that it was new to him. Because this is something that we kind of do day in and day out in mental health. It seems like almost all of my patients, I'm suspicious at least of almost all of my patients, that they have some level of suicidality. And I'm almost sometimes surprised when they're not. Now, of course, this changes depending on what patient population you're working with. But in general, it was a good reminder that my day to day looks different than other people's day to day. And so you really want to come at this with fresh eyes every single interview, and you just want to assume that this patient doesn't really want to see you. In cultural and culture, we call psychiatrists shrinks, and that seems to me to be a pejorative term. It doesn't seem to be a term that I particularly like. We also call, them psych doctors. Oh, you have a mental health illness, as if that mental health illness is different from any other medical illness. It's in its own category. And I even know that this is true in my own life. It took me at least a year of internship in order to seek out my own psychiatrist, even though I was prescribing uh, these medications to patients for an entire year of my training. I didn't feel comfortable seeing a psychiatrist myself, even though I'd already had 2 years, a couple years of therapy prior to that. And I think honestly, it was just because of the social stigma that's attached to psychiatry. And this is the field that I chose. So if anything, I should be one of the most open-minded people to this. And I still felt a considerable barrier myself. Um, Knowing this can go to great lengths with patients. I have seen patients in the emergency room department before, and I've recognized that they have shame, and I've just very gently pointed out that many people feel the same way, and you can just see the tension kind of leave the room, and it's not a difficult thing to do when you realize it, and you can say with simple things, you know, I don't think anyone would want to see a psychiatrist. I am impressed that you were able to, and so there's ways you can enhance their ego functioning even in the middle of the interview with these very simple phrases, especially if you see it kind of written on their face. The next thing is besides shame is you want to focus on a strong therapeutic alliance. Now, there's been kind of controversial literature. It does, and the problem with therapeutic alliance is it's difficult to answer the question, does successful treatment happen first and then a strong therapeutic alliance forms because it's like this doctor or mental health professional knows what they're doing? Or does the therapeutic alliance form first, and then after that, from that, then good outcomes happen? And so that's what makes this a particularly difficult area of research. Arno 2012 recognizes this. It's a very short article worth a read if you have a second. And basically, they said that therapy, so this is not medication, but therapy, is 5 to 16% more effective with a strong therapeutic alliance. So you're getting an additional 15% effect, which is really nice. And then they said that medication adherence has also been shown to improve with psychosis, as well as a number of other mental health diagnoses. Um, so I think that forming a strong therapeutic alliance, creating an environment that is safe, where they can talk about anything, is one of the most important things that you do prior to even starting the examination. And this happens with both verbal and nonverbal cues. I was just talking to a patient even this last week, and they were talking about their sex life, and they started off by saying, you may not want to hear this because, of course, in an average conversation, you wouldn't get into your sex life, but with psychiatric medications and in therapy, it's very important at times. And then they actually stopped themselves and they said, "Oh, wait, no, you're a doctor." And so I actually I found that very encouraging because it made me think, one, this person was kind of free enough to just kind of talk out loud and muse with me. They felt comfortable doing that. And then they recognized that this is a different kind of environment than just a casual conversation and that they can really bring anything to the table. So now, kind of a big question happens, and there's no real right answer to this. And I think basically any person you talk to is going to have a different way of going about this next step. And I don't really have an answer. This is just what I propose. So, because the question is where do you start the interview? At some point, you're going to have to ask a question, and what you need to know is what question do I ask? Some people will say you can let the patient talk for 5 minutes and just kind of understand their mentation. I typically kind of just let the patient start talking, and then I'll piggyback on kind of whatever subject they're on and just kind of go with the flow. So if they start talking about substances, I'll get the section on substances that I need. If they start talking about their sexuality, I'll talk a little bit about their sexual history. Now, of course, you have to be prudent, and that's why I mentioned this. Is it's probably easier to start with just kind of basic questions that you'd ask anyone off the street. Everyone would feel comfortable answering, except for people that are very paranoid or psychotic. Um, because that builds some rapport prior to getting into some of these nitty gritty. So you notice it says start with social history, and then the first question is like, where do you live? It's not how many sexual partners have you had in the last year, because you're not going to walk up and meet someone for the first time and use that question. So I kind of like to have this unfurl like kind of a casual conversation. And in America, how do we talk to people? The first thing I ask a new person is, well, maybe what do you do? It's that kind of boring first question. In psychiatry, that's very relevant, actually. And then, the next question, where do you live? Where do you come from? Where's your family from? How many brothers do you have? How many sisters do you have? Um, have you been married before? Have you been married, before that? Is this like your first wife, your second wife, or your first or second husband, or, what happened to them? And, of course, the marriage questions will come a little later, but you can kind of see how what I try to do is just create this as kind of a natural back and forth conversation that you have with anyone. But of course, knowing that underneath that back and forth, I'm going to be digging into parts, asking more specific questions for my own. And really what these questions are for and the purpose behind these questions is you already kind of know, where do they live? Well, I live off the corner of the 10 and Colton. Well, so you now know they're homeless, right? And that's giving you some level of functioning. They're not doing probably too well in this world. Either they've been homeless for a long time or they're newly homeless. And then my question is why for both of those? Who do you live with? This gets to their social support system. So it's different if someone has suicidal thoughts and they have a very good social support system rather than someone that lives alone with a bunch of guns, right? That person, that second person, would be much more afraid of. How many children do you have from how many relationships? So how stable has this person's relational life been? It's different having a patient that's never been married versus a patient that's been married for 50 years to the same partner to a patient that has been married 5 times. The latter, of course, demonstrates relational instability, which is one of the criteria for borderline personality disorder. So it makes me begin to think in terms of different diagnoses. Typically, also schizophrenics don't get married. So that would push me maybe if they've had no relationships, you're thinking more of like maybe schizoid personality disorder or schizophrenia or maybe something like that. They're not always schizophrenics, of course, but I'm just saying what my mind starts thinking about. Um, where do your parents live? So again, just getting that how much family support do they have in the area, and what are those relationships specifically like? I like the question, and I'll ask it often. Tell me about your mom and your dad. If you could use one word to describe them, what word would you use to describe them? And patients will often be very frank with you. Controlling, the most manipulative woman I've ever met, or a wonderful person. And these are all phrases that I've heard from my patients. And this slide just emphasizes again that what we're trying to do with the social history is getting their lifetime functioning. Now we move on to questions about college and schooling. And this can either be, there's a difference between a person that's dropped out at 10th grade in order to have their first child, than a person that has completed a doctoral degree versus a person that's completed some college and then stopped college. These are all different people because it gives me a level of functioning that they've had in the past. So for example, let's say this is a patient that dropped out of high school at the age of 16. They were doing drugs. And now let's say they're employed in the service industry. Maybe they're serving tables or busing or working in a warehouse. Well, this is probably as good of a job as this patient can have. They're operating according to their native socioeconomic status, kind of where they came from. Now you take a patient, and this is a patient that I remember, and he was selling $1 million paintings in Laguna, and now he's homeless. Well, how did that happen? How did you go from selling $1 million paintings in Laguna, having graduated high school, gone to college, had your own art studio, to being homeless? And that would be our next question. In his case, he had a traumatic brain injury. He fell asleep in the snow and had an anoxic brain injury as a result. So this will lead you down different paths. You always have to, if something doesn't make sense, you just ask why. What kind of jobs have they done in the past, and what was their most recent job? So another way of comparing past and present. If they don't have a job, I often want to know what kind of resources are available to them because I want to help them in any way I can. If they only have $1,000 a month, which some patients have, maybe they can afford a room and board with that if they're homeless. Some vets, I've seen up to $60,000 a year from the VA for long-term disability. So you can have a patient that only makes 1,200 a year, 12,000, excuse me, a year, or a patient that makes $60,000 a year. Both of them are unemployed. And obviously their resources are going to be different. In fact, the patient that made $60,000 a year, his biggest issue was his methamphetamine addiction because he had so much extra money, he could basically get meth whenever he wanted. And so this can even, of course, influence their psychiatric and medical diagnoses just based on how much money they have. The other last question here is kind of a brief developmental history. This can get very long. That's why there are child and adolescent psychiatrists. So when your mother was pregnant with you, were there any problems? So starting from pregnancy, you're a person, your brain is forming. Was there any problems with that? Sometimes if did your mother ever use any substances in her life? If she ever used substances in her life, then I have to ask the question, did she smoke while you're pregnant? Now, a lot of times patients don't know this, but that still gives me information, because they'll have some suspicion either way, like, no, she was the kind of person that probably would have kept smoking, or she was the kind of person that wouldn't. And so that will still give me some information in terms of how their brain might have developed over time. And then, of course, you can ask beyond birth, first year of life. The biggest thing are respiratory illnesses and being intubated or in the ICU because that can cause anoxic brain injury. And then milestones, walking at one, first steps, first words at one, talking first. I already said first words at one, walking, and walking, talking. Well, there's one more, but it's escaping right now. So and then you can go beyond that. We've kind of already covered some of the others in this slide. Now you go to childhood education. Have you ever been held back? Advanced classes, 504C, or an IEP. An IEP in California is an individualized education plan. It is very formal, and it has to be approved by the district. And it essentially costs the district money. Um, so it's a higher bar to get. The 504C is not like that. It's very informal. But it says that were having maybe some problems in school. And typically I'll just ask these all together because I don't want the patient to think that I'm presupposing anything of them. So I'll just say, did you do well in school, or did you do poor? Were you in any advanced classes, or like GATE classes or AP classes, or did you have the opposite, like special education or IEP? Because I don't want to presuppose anything on anyone. I just want them to be able to speak for themselves. And so typically that's how I'll ask it. So that's it for social history. So definitely a little longer. Well, I take that back. This is social history too, but now I'm throwing in some medical questions that in my mind just kind of naturally go with the social history. And this now gets into trauma. So you notice I put these at the end. I don't want to come out of the gate social history. So did your parents hit you? Did you ever see any domestic violence? Have you ever had any intimate partner violence? Now, sometimes you have to be very specific with this because people think different things are abuse. So, for example, I just heard of a patient that one of my colleagues was talking about, and this patient was touched by another girl in her private parts when she was about 13 or 14. And when asked about abuse, she flat out denied it. And and then when the person brought this up, well, this girl touched you, could that have been molesting, or could that have been um, some like a sexual abuse? The patient said no, and was surprised that they even thought this when this was non-consensual touching, because women can't molest other women. And so they just thought women can't molest other, that's what the patient thought. Women can't molest other women. And this is a woman that touched me in my private parts. I didn't want it. I actually think about it and it troubles me still, but it certainly wasn't abuse because women don't abuse women, men abuse women. And so this is an area where sometimes you have to be a little more concrete. You can start out by saying, have you experienced any abuse? But then you really do want to just use the words like touched, hit, and you want to be specific. Touched you in your private parts or hit you. And then you also want to be specific as this is something that they didn't want or they want. I've had patients say, yes, he was a male. Another boy has touched me, and I said, oh, that must have been. And this was my mistake. I said, oh, that must have been difficult. And he said, well, yes, because of course patients are going to agree whenever we presuppose something. But then we kind of looped around to it later, and I was like, wait, so tell me more about when this boy touched you. What was that like? And he basically disclosed that this was somewhat consensual, actually, that he enjoyed the experience, that it happened once and never happened again. So this isn't trauma, right? It's not trauma or abuse when two teenage boys are consensual. Now, I mean, I know there'll be people out there that are cringing right now because it certainly is not, and I don't want people to be confused. It's certainly not something that is probably healthy developmentally. But I mean, in this case, I really had the thought from the patient that it was this one-time thing, and I inquired about other experiences, and it wasn't a part of his current psychology or his past psychology, and so I just kind of took that at face value. Um, Other times, and that was the only time that that's ever happened. So I just provide that as a counterpoint. Almost always, this produces some level of pathology, either in the past or present. The other question, of course, have you had any problems with the law? Or sometimes when I'm interviewing people with like an antisocial personality disorder, do the cops ever bother you at home? Are they kind of always coming around? Because it takes the blame off the patient and kind of puts the blame on the cops. Since they're like, yeah, I mean, these guys are always bugging me. And then I say, oh, what are they always bugging you about? And so it's a way to get legal history without putting the patient in a position where they have to say they've been up to no good. And then you just have to straight up ask sometimes too, have you ever been to jail? Have you ever been to prison? What were you to jail for? How many times? How long? And whenever you're guessing numbers, you always just kind of overestimate. So you're in jail. So were you in jail like a year? And they're like, no, it was only a month or two. And I'm like, oh, that's much better than a year. So there's ways you can even create psychological safety and show that you're okay if they were even in a jail for a year and they've been in jail a month. They feel safer because they disclosed that with you. You do the same really with substances, and that's how I ask the substance questions is you want to find a nice number that's reasonable, but kind of on the higher end. And then it gives the patient the opportunity to use the defense of denial. So, denial is one of the most common defenses in substance use. And it basically says, I'm not an alcoholic because I start drinking at noon. Alcoholics start drinking at 11 a.m. or 11:59. But since I drink alcohol at noon, I have no problems with alcohol. And so, that's kind of how you phrase the question. So, do you only have like a 12 pack a day of beer? Oh, no, I only have a 6 pack a day of beer. Okay, that's risky use. And you don't show any emotion when they say that. You just say, okay. And then you keep asking, well, are those regular beers or are those strong beers like nice IPAs or something like that? Because the fact is a Coors Light is 3%, and then an IPA is like 8%. Sometimes they can go up to 10%, and so having three Coors is the same as having one IPA, and so it's important to know what they're drinking as well. And then if they pour mixed drinks, I just have one drink at night. Oh, okay, and your favorite. A lot of patients have like their favorite cup or their favorite chair, something that they drink in. So you pour one or maybe even two nice glasses for yourself at night. You just use their language. And then they say, oh, yeah, actually, I do pour two. And then I say, oh, and it's about what kind of cup is if you were to just kind of guess based on the size. And I signal with my hands like this big or this big. And, typically they'll give me about the size if it's a small cup or a larger cup. Um, and so this is kind of how I go about the substance history question, just assuming and kind of overestimating a little so they can rely on their defenses and not feel bad about themselves. Because I'm not trying to increase their shame. I don't want them to feel bad about their substance use. I want them to change. And you can actually change without people feeling that bad about themselves. I really believe that to be true. This first question for substance here on the top, this is a great screening question from NIDA. There's actually a study, and if you're ever interested, I can send it to you, that says this screen's pretty much about 100% sensitive for substance use disorder, meaning it catches all of the people with a substance use disorder, but there'll also be people in that that do not have a substance use disorder. So that's the goal with our screening questions, is to catch everyone with a substance use disorder and then figure out which ones don't have it. And that question is, in the last year, have you used any medications that were not prescribed to you, or have you used any illegal drugs? And that's really it. And then the other questions I throw, because they're on the NIDA assist, throw in, have you smoked any nicotine products, marijuana? Smoked is nice in general because it could be marijuana or nicotine. And then do you drink? Everyone pretty much knows that that refers to alcohol. Other drugs, it kind of depends on my index of suspicion and what era I'm in. If I'm in an addiction clinic, of course, I'm going to be asking every single substance because When you use one substance, it's much more likely that you're going to use another substance. But you'll be surprised. Some people will be using meth that you do not expect. So it just depends on how many of these patients you actually want to catch, and how valuable you think that is. In general, I think it's fairly valuable. Have you ever used meth? Have you ever used cocaine? Have you ever used LSD? Have you ever used spice, inhalants, synthetic cannabinoids, and the list goes on. So the weird thing is psychologically for us as humans, it's harder to deny specific questions than to deny generality. So if I ask someone, do you do drugs? No. And the reason why they don't do drugs is because marijuana is legal, and because alcohol is legal, and because drugs are just meth. So, do you use drugs? That won't work very well. Do you use methamphetamine? Yes, I do, but you don't use drugs. And I've had I remember a patient. She was in the emergency department. I can't remember what for. I think she had a positive urine drug screen for methamphetamine. And I said, "Do you use meth?" And she said, "I am not a user. I will take meth every other day." And so, these words are very idiosyncratic depending on the person. In her mind, use meant she was, bad and negative. She was casually taking it. And so then, of course, I adopt that language and I say, okay, how often do you take meth? And then she was able to kind of give me a quantity. Um, Sometimes, depending on how guarded they are, of course, you can't get very accurate, but you kind of want to get at least the duration, since meth is neurotoxic and does hurt the brain. You want to get the duration of exposure to meth, any problems from meth, first use, last use, and then if they've have what kind of pattern of use. Is it daily? Is it every other day? And then how much? Is this like an 8 ball? Is this like a gram? Like that would be a very lot. How much are we looking at here? And so that's what you ask for every substance. So if they answer yes to anything, yes, I smoke, yes, I drink. Okay, next thing I ask is, when was your first use? When did you last use it? How often do you use it? How much? And then have you ever had any problems? How long have you gone without it? Because that'll help inform your treatment. If they got a lot of help from sober living, maybe they should go back to sober living, right? If they got a lot of help from Nicorette gum, maybe you should go back to Nicorette gum. So it makes your treatment planning a little easier there. The next section after substance use is psychiatric and social history and psychiatric history and family history. I like jumping back and forth between these. And the reason why I like jumping back and forth between these is because it's another area where I feel like, at least, or I hope, I'm reducing shame. Because sometimes it's easier talking about other people's problems than your own. And sometimes patients just haven't drawn the simple conclusion, you know what, I might be depressed because my dad is. And they think it's just because of them. And so depending on where I think they're at in the interview, if I feel like they don't still feel super comfortable talking about their own mental health diagnoses, then I'll just say, well, how are your parents doing? Tell me about your parents' mental health. And then that's when they kind of spill the beans a lot of the time and like, oh, they are just messes. They're messes. My dad drinks, my mom smokes, my mom's tried to kill herself 3 times, right? And you want to ask 4 things in the family history. You want to ask about any psychiatric hospitalizations. You want to ask about suicide attempts. You want to ask, and these are blood relatives, because the purpose of family history is to figure out how likely they are to have these things. So I don't care if it's an adopted brother. That's not family history. That's just someone else in their family have it. It does tell me something about the social environment, but it's not as important genetically. So you want psychiatric hospitalization, suicide attempts, history of mental illness, incarceration, and then you can add another one too, any medications that have been effective. Because as we know too, there is a genetic component of medications being affected, and if mom did really well on Zoloft or sertraline, then it's more likely that this patient is going to do well on Zoloft and sertraline. And of course, the converse is true as well. And sometimes I'll just go back and forth. So, oh, so dad struggled with alcohol, did you? Yeah, so you can also do this before your alcohol if you feel like they're not quite open up. Or I'll just say it again. Wow, you really didn't struggle with alcohol at all when dad had it? And sometimes you'll get a hit then, they adamantly denied it and now they're like, well, actually, because they're kind of being able to see the linkage in the moment. And then for personal psychiatric history, you always ask patients, how many hospitalizations have you had psychiatrically? How many suicide attempts? Did you ever self-harm, cut, burn, hurt yourself in any way? What kind of medicines have you been on in the past for your mental health? What kind of medicines are you at on present in your mental health? Any past other treatments? Did you see therapists? Did you see a psychiatrist? Did you ever go to partial, intensive outpatient, residential, anything like that? And then any prior psychiatric diagnoses. Did you ever get diagnosed with anything? Usually, you just take these with a grain of salt because everyone kind of has a different opinion in psychiatry. Next is the medical history section, and here this is basically exactly like the SOAP note. So you just ask the patient about their medical history, their surgical history. The most important part of the surgical history is bariatric surgeries because those are going to affect medication absorption, or if they have short gut or things like that. You might want to, in that case, use something like a liquid formulation typically tends to be absorbed a little better, and you also probably want to monitor with levels, but it's important to ask about bariatric surgeries in general for that reason. Then would be their current medication list. Always encourage your patients to write down their current medication list so they can just hand it to their doctors, because a lot of the times they don't have this easily on hand. And then allergies, specifically allergies to any medications. Next would be just going into the chief complaint. They may have already brought this up. A lot of the times patients, this is all they want to talk about, right? What actually brought them in. So that's why I kind of sometimes sidestep this at the beginning. They'll bring it up on their own. But if they haven't, then you can just ask them what's been bothering them. And then you want to get kind of an old carts history, just like you would in any subjective HPI part, or the mnemonic I remember is OPQRST, onset, provoking and palliative factors, quality. So, in psychiatry it would be kind of like, what does it feel like? And then timing or severity. How bad is this? How much is it affecting your functioning, your day-to-day activity? That's the most important thing in all of psychiatry is functional impairment. And then does it every day? Does it come and go? Is it all day long or only part of the day? How much is this kind of dragging you down? After that then is the psychiatric ROS. Now in the rest of medicine we have a regular ROS, and I put a picture of that over here, but in psychiatry we're going to be doing these screens: mania, borderline, PTSD, anxiety, psychosis, depression, and sleep. Now, of course, if they came in with depression, you don't have to screen for depression in this section because you've already gotten into your HPI. Same with, let's say, a sleep complaint. Mania screen. Have you ever felt incredible, like you weren't on drugs? There's basically two ways to screen for mania. One is to really target that euphoria aspect, and then the other is to target the sleep aspect. And so, patients will generally say, yeah, no, I felt really good. And then you say, how long? And then they'll say, like a day. And then that's not mania, because mania needs to last at least a week. And then, if they kept saying yes, so they felt amazing for a week, I mean, a typical manic episode really lasts around 6 months. So it's probably not, but you would have to dig in more to those dig fast criteria if they did screen positive for feeling amazing, or if they haven't slept well in a week and kind of felt amazing during that time. And then you just use the dig fast criteria: distractible, irritable, grandiose, flight of ideas, increased activity, speech, and then talkativeness. And then, the S can be for decreased sleep as well. Borderline screen. A lot of people end up having borderline personality disorder. It's about 20% of our 10 to 20% of our outpatient population is borderline. About 20% of the inpatient population is borderline. A lot of these patients end up getting diagnosed with bipolar mood disorder. And so that's why they'll say, I feel amazing. But what they're really describing is these rapid shifts in mood, that they feel amazing and then they feel angry and then they feel sad. So a lot of the times I'll just kind of present it that way. Now, I'll say, now there's kind of two different types of, let's say, bipolar. Some people will feel amazing for like a week, 2 weeks. They won't sleep during this time. They don't even feel like they need sleep. And then there's another kind of bipolar, which in reality is kind of more borderline. That's what we're talking about here. And in that case, patients become a lot more moody, a lot more irritable. They'll feel like they're in love 1 second, and then the next second they'll be arguing with their partner, and they don't know why. And a lot of the times you can tell by their eyes that really it's the second one, that it's the borderline kind of features that the patient is really more self-identifying with. So the question really is, do you often get moody? And this has a pretty high sensitivity. It's like upward of 90%. Um, like you can even fly off the handle at a moment's notice and then later feel great. You can follow up any positive screen with a scale called the Zanarini scale. It just has the diagnostic criteria. The next screen that you're going to go for is the PTSD screen. Of course, in order to have PTSD, you have to have a trauma. Now, of course, trauma can be broadly defined. This can be trauma that you've seen, or trauma that you've experienced, but also there's a different type of trauma called vicarious trauma. So let's say you're an emergency room doctor and over you just see gunshot wounds, or you're a psychiatrist and over you hear about someone being molested or raped. This can actually cause trauma in us doctors. And you can think of other professions where this would happen as well, maybe like firefighting, where some of their friends have been hurt in the line of duty, or policing would be the same way. And so vicarious trauma is something that we often forget to screen for, but that's an important aspect of trauma. And then you really just want to ask them what the experience is like, if it affects their mood. And these are the other criteria for PTSD. Does it affect your mood? Do you feel on edge? That's the hypervigilance aspect. Do you avoid situations? You have to have avoidance, otherwise it's not PTSD. And then the re-experiencing, or flashbacks, or nightmares, all of that would be involved in this last question. And you need each and every one of these in order to meet diagnostic criteria for PTSD. So you can have trauma and it not meet criteria, and you can have trauma and it can meet criteria. Anxiety screen, are you a worrier? That's really all you have to know. And then if they are, then you can just follow up with a scale like a GAD-7. Psychosis screen. Now this is tricky because typically the people that are psychotic don't want to say it. And then the people that aren't psychotic do want to say that they're psychotic. I don't really know why that's the case. So if you flat out ask someone, are you hearing things? Are you seeing things? The average person, even if they are, is going to say no. And that makes it difficult. So you kind of have to kind of poke around the edges. You have to figure out, you just kind of have to get them talking about whatever it is they're afraid of. Like, is there someone kind of out to get you? Do you feel safe here? Or you can just always kind of straight up ask them, what if you know they're just like mumbling to themselves, talking to themselves, scanning the room, and you're like, this person is interacting with someone else that I can't see. Then you just say, who are you talking to right now? What are they saying? And a lot of the times the patient will start talking. Oh, they're saying, oh, wait, no, there are no voices. And I always think that's kind of a giveaway because they've already let the cat out of the bag and said that they are hearing things. And then they quickly realize that they're not supposed to say that. So I just encourage them and I give them examples. The most common auditory hallucination in men is that they're gay. And I often tell that to patients to let them know that this is something that I know about. And the most common auditory hallucination in females is that they're a bitch. So I just say, the most common auditory hallucination in males is this, females is this. And I just would never want you to experience that. So that's why I ask if you are. Because a lot of times patients feel embarrassed. And I'll maybe even say that. And sometimes you'll get some more positive responses when you couch in those terms. Depression screening, just have you lost interest in doing things, or do you feel depressed? This is the PHQ-2, and the PHQ-2 has a sensitivity of 90-95%. And then if that screen's positive, then you can follow up with the PHQ-9. Sleep, you can ask a lot of questions about sleep. This is just a few. How many hours do you get of sleep at night? Patients will say, well, I wake up, I'm in bed, I don't know how many hours. And you say, well, take that time away that you're just sitting there and awake. How many hours do you sleep now? Do you still have problems? Do you have problems going to sleep or staying asleep? And then the sleep apnea questions, which are very important. I include this in the sleep screen. Do you snore? Do you have morning headaches, daytime fatigue, or ever been diagnosed with sleep apnea or had a sleep study? Do you take naps? I ask this just for general kind of sleep hygiene. See how long their naps are and stuff like that. If their sleep apnea screen's positive, then they need a sleep study at a sleep lab. So that finishes the subjective portion of our interview. The next is going to be our objective portion with the mental status exam. The subjective portion in psychiatry is very big, so you can already tell we're well into talking about the interview. The rest of these slides should go a lot quicker. We just had to spend a little more time on the subjective part because it is a lot different from the other branches of medicine. So here's the mental status exam, and what I've bolded here is really the parts that you have to do with a question. So none of the other parts that aren't bolded, you really have to take note in, right? Because you're just going to think after when you sit down at your computer, what did they look like? Were they nice to me? Did they look at me or did they look down? Were they moving funny? Were their muscles normal size and tone? Did they talk okay? And then this is the first question you have to ask them is, how do you feel? That's what their mood is. The affect is what you think they feel. So they could say, I feel great, but then they say it very flat. Well, I'm not going to say they feel really great. Thought content, do they have any suicidal thoughts, homicidal thoughts, auditory visual hallucinations? You have to ask about that. And delusions. Thought process, this is how they think, linear, disorganized. Orientation or clock draw, so this would be more for a consult that you want to draw a clock or do an attention or orientation task. Memory, you're just going to be able to, you don't really have to ask this, but if you did, you would ask them to remember 3 things and you'd give them 3 things like church, daisy, red. You'd make sure they absolutely know those things, and then in 3 minutes you would ask for them for again. Insight and judgment will be last. We're going to go over each of these in turn, so we'll spend a whole slide on each of these to get a feel for what it's like. So how do they look? So we have a person here. I would say he's well-groomed. I would say he's wearing a tie. I'm colorblind, but I would say he's wearing a shirt with a nice wristwatch. And then I would say he's probably going to interact with me pleasantly. His eye contact is downward. His motor is no psychomotor agitation or retardation, no PM&R or PMA, as we would say. Musculoskeletal, good bulk, good tone, and speech, regular rate, rhythm, normal volume, regular prosody. You typically want to include all of those. So again, you want to include in their appearance, dress, grooming, and any physical characteristics. The interaction can be pleasant or unpleasant. The eye contact, appropriate, avoidant, downcast, or intense. Motor, agitation, or retardation, or none of them. Musculoskeletal, bulk and tone. And then speech, you want to get rate, rhythm, prosody, and then volume. Prosody is how I'm talking right now. So right now, as I talk, the rhythm, it's rhythm. So prosody is the intonation, the inflection in my tone. So you can tell that there's some words I'm going up, some words I'm going down. And during normal conversation, we all have these kind of differences in intonation. Some people, though, they don't have this intonation when they speak, and really you would just say in that case that their prosody is abnormal. Rate, of course, is the speed, how fast are they talking. Volume is how loud, and then rhythm is this would be a slow rhythm. It kind of relates to rate, but it is a little separate. It's just kind of escaping me right now. I wish I could explain it a little better. Oh, during motor, you could also put if they have any tics or bradykinesia or dystonia or tardive.
This could also be an appearance. You can kind of mix and match these sections. So how do they look? So in this case, again, I just trying to give you as many examples as possible because I think that's how we're going to know this. This person looks like their stated age. They're well groomed. They're wearing a blue shirt with blue jeans. They're very pleasant. They have great eye contact, appropriate. They have no psychomotor agitation or retardation with normal bulk and tone. Regular rate, rhythm, normal volume, and prosody. So that's how you would document it. But then we can look at a different kind of person. So how does this person look? Well, they appear older than their stated age. Maybe this person says they're 30 years old. This person does not look 30. They look much older than that. They're wearing mismatched clothing, a large coat, despite it being 100 degrees outside. So that's noteworthy. They're malodorous, and they have dirty, long, dark hair. Their interaction is guarded. They're worried when they talk to me. They don't want to disclose. Their eye contact is very intense, or staring, you could put. They have psychomotor retardation. They're not moving very much. They're kind of standing still. They have thin arms and legs with sunken temporal muscles. You don't really see that in this picture, but I'm just saying something that could happen if a patient is malnourished. They'll have the sunken temporal structure right here. And then speech selectively mute at times, low volume, decreased rate, and then abnormal prosody. So they are talking like this. Next, beyond those first four, we'll go next to mood, affect, thought content, and thought process. Mood is how they feel according to themselves, and usually you put this in quotes. So you just say, how do you feel? They say, I feel great. And then you just put great in quotes, and that's it. Affect is how they feel according to you. And it includes these separate dimensions: quality, range, congruence, and appropriateness. So if they say, I feel great, then I would say, well, no, they don't. They feel, let's say, sad. The range is how big something is. So are they sad most of the time? Are they sad all the time? Or do they not have any range at all? So you can have sad and it would be constricted in that range, for example. They don't go outside of sad. But sometimes they do. They can be more blunted, where that's even less range, or flat, which is even less than that. And then congruent or incongruent. So if this person says they're sad, and they really are, then I would say that they're congruent. If they say they're happy, but they're actually sad, then I would say that's incongruent. And then whether that emotion is appropriate to the interview or not. If they're talking about sad content and they look sad, that makes sense. And also mood lability could be involved in that as well. Thought content. Do you feel like hurting yourself, hurting others? You've already really asked about this in your subjective, so you don't really have to ask it again if you've already done that. You just have to write it down. And then any hallucinations, which could include auditory, visual, gustatory, olfactory, and tactile. So you actually have a number of different types of hallucinations. And then delusions. They can be paranoid, non-paranoid. There's a bunch of different subtypes for delusions as well. Thought process, how they answer your questions. We'll get into this in the next slides, but examples would be linear, circumferential, tangential, flight of ideas, and then disorganized. So, how do they think and feel? This patient says, I feel great. I look at him, man, this guy does look really happy. He looks happier than I think most people I interact with. So I would say he is congruent, he looks happy, he is euthymic, which means true mood, he's full, he has a full range, he can be emotive in that proper range and to its fullest, and he's appropriate to the content of the conversation. He doesn't have any suicidal or homicidality, no hallucinations or delusions, and he is linear, which means he answers my questions, and goal-directed, which means he also just answers my questions. It's basically the same way of saying the same thing. Now, how about this next person? When I ask him how he feels, he says, and I just often just write this down, how do you feel? They are after me. That's how he feels, I guess. I would say his affect is paranoid, blunted, congruent. He seems paranoid to me, and he's saying I'm paranoid, basically, but inappropriate to the content of the conversation. He doesn't act how another person would act in their emotions when they're in front of a doctor. Thought content, he denies suicidality. He endorses diffuse HI against them. If that's the case, you don't have to report this. You only have to report HI if they give a specific target. That's what the Tarasov rule is. And then paranoid delusions regarding the people that are trying to kill me. We'll often also use this RTIS, which is responding to internal stimuli, which means they're mumbling to themselves or scanning the room, looking around, interacting with something that's not there. And then the thought process would be disorganized. So if you don't have it already, just want to explain the difference between mood and affect again. And I found this wonderful picture of Kristen Stewart because the Twilight movies all just got released on Netflix. And she is a okay actress, but very poor at times in those first movies. And sometimes she says, I am amused. But does she look amused? Or I am skeptical, or furious, or wistful, or confused, or bored, or sarcastic. So, they can say I'm amused, but if they don't look amused, then their affect is not amused. And again, just talking about each of those dimensions. For quality, you could say euthymic, which is just normal. You could say dysphoric, which is sad. Euphoric, which is elated. Worried. Tearful, paranoid, all of these are good quality descriptions. For range, it could be full, expansive, constricted. I would say she's kind of blunted here. Her affect is blunted. Flat would be just totally no emotion at all. You can't have any less emotion than flat. Blunted is the second least. Constricted is the third least. Congruence or incongruence, inappropriate. So I would say incongruent, Kristen Stewart, inappropriate to the content of the situation. You should be having more expansive affect if you're in a movie. 4 dimensions to SI. So we have a bunch of questions we can ask. And again, you can just move these into your subjective part, but I decided to just put them here. So it's just like substances. When was your last suicidal thought? And then you want to ask specifics. Did you think of shooting yourself, hanging, overdose, stabbing, jumping off a high place, driving off a road? It's harder as a human to deny a specific than to deny a general. So that's why you always want to ask specifics. Means, can they do this? Do you have a lot of pills in your home? Do you actually own a firearm? Could you get one? And then intent. Have you ever acted on your plan, looked at the medication, opened the bottle, set out the pills, held a gun or a knife, stood on a street corner, written notes, given away your things, or said goodbye? And of course, you're going to tailor this depending on what kind of symptoms the patient is reporting and what kind of specific plans the patient is reporting. But basically, the reason why you want to go over each of these dimensions is because having no thoughts is farther away than having thoughts. Having thoughts with a plan is even further, closer to actually completing suicide. And then having intent is even further. So kind of the more they're answering, the more worried you're getting. This is particularly true if they have firearms. 50% of successful suicide attempts are due to firearms. So really you're asking this to help with your recommendation portion, to kind of trying to limit the means that are available to the patient. Here's some great books on suicidality. There's a whole section of psychiatry called Suicidology, the study of suicide. The book that I would probably recommend first is this Practical Art of Suicide Assessment. It's just older, so that's why I put a newer book, The Clinician's Guide to Suicide Risk Assessment and Management, but both are great. What do I do if a patient is homicidal, right? So does anyone just kind of make you mad? So you're not going to come out straight out of the gate and say, who are you trying to kill? Because everyone's going to say, I'm not going to try to kill anyone, right? And then you're just going to, once you kind of dig, this person really do they make you so mad that you just kind of want to, I don't know, like never see them again in a kind of like final way? You kind of hint around it. And then you try to get in if they've ever had these thoughts, means, intent, or plan. And then before you do that, because you really need to do it, before you raise their suspicion, you want to know who the person is. And if the patient can get in contact with them, or if I can get in contact with him, because it's my duty to warn them. But you're kind of dancing around a little bit, trying not to make the patient too suspicious. And if they do have a known target and they really do want to hurt the person, then you do have to call the sheriff or the police and do everything within your power to get in touch with that person and then document it. But this is for specific people. Again, if I have these vague threats toward them or they, and it's kind of psychotic, there's nothing that needs to be reported in that case. So now with thought process, this is very confusing for kind of the uninitiated. The fantastic book is the Mental Status Exam, third edition. They go through this. It's only a 90-page book, so it's a really easy read. But this is how they explained it, and I thought this was very helpful. So here you have a question and you have an answer. And let's say the patient just straight answers it. So I ask, where do you live? And they say, I live in Loma Linda. So then they would be linear or goal-directed, or you could say linear and goal-directed. So there's a goal. They answer the question. Next would be something like this, where I ask a question, where do you live? And then they start by not answering it. And they say, well, I've lived a lot of places. I've lived in Beaumont. I've lived in Northern California. I've even lived in Nevada. But I live in Loma Linda right now. So they're able to get back to the original question that was asked, but they just kind of take a different pathway. Do you know what this would be called? This is called circumferential. So they get around. It's kind of making that half circle. The next type of thought process, you ask a question and then they get off track and they never arrive at the answer again. So where do you live? I've lived in Beaumont. I've lived in Banning. I've lived in Nevada. And just today I had a bowl of cereal in my favorite place. So yeah, they're just kind of getting further and further away and they never answer the question. So this would be tangential. There's another way that patients can answer, and that is they don't ever answer. So all the rest, none of them are going to answer, but they're going to go about not answering in different ways. So this tangential, all their points are connected, and you can easily see how they're getting there, and they're just kind of weaving their way there. But what they could also do is they could jump from concept to concept. So I ask a question, where do you live? And they say, I've lived in a lot of different places. I've lived in Beaumont. Oh my goodness. So that's A, is where do they live? Oh my goodness, Beaumont. What a beautiful city. I've seen so many beautiful cities in my life. And now they're talking about B. Now they're just focused on beautiful cities. I've been to San Francisco, but man, there's a lot of fog there. Foggy. Everything can be so foggy. I think of like London. I've never been there. London. So you can see they're jumping from like places they've lived to then beautiful places to then fog. So they're sticking in those things, and you can kind of see the connections, but they're not like amazing connections between those things. This is actually flight of ideas. And it typically happens in the way I just said, where the last word that they say is kind of a trigger word for the next concept. And then they talk about that concept until they have a new trigger word. So this will typically happen with increased speech, increased rate, and it's characteristic of mania. But it can happen in other things, and so it's just, that's what it is. Here we ask a question, and now there's no discernible pathway at all. Like, I have no idea what they're talking about. So where do you live? And they're not even getting close. There's really very little connection between the ideas. In this case, this would be a disorganized thought process. Now, there's different other types of thought process, like word salad and things like that. If you're interested in those, I would just say go through this book, but these are the major thought processes that you typically document. And of course, you typically document them at their worst, not at their best. So even if they're linear 90% of the time, but then 10% of the time they're disorganized, you could just say it, right? They're linear most of the time, but there is some thought disorganization. But typically you would just say they have disorganized thought process. The next part of the mental status exam are orientation, clock draw, attention, memory, insight, and judgment. So we're almost done with this. For orientation, you want to ask them about person, place, time, event. For clock draw, I like to separate it out. First, what I want you to do is draw a circle. Next, I want you to put the hands in the numbers in the clock. And next, I want you to set the clock to 11:10. That's exactly how I say it. And then attention is serial 7. So you would say starting at 100, count down by 7, keep going. Don't give them any hints. They have to keep going, keep counting down. Or if they're not good with numbers, you can ask them to spell world backward. If they can't do either of those, you can always do months backwards or days of the week backward. All of these would be attention tasks. Memory, you would have immediate and delayed recall, and like I said, we'd use 3 objects, so like church, daisy, red. For delayed recall, you really want to make sure that they're in their mind, so I would not move on until they repeat church, daisy, and red. And then after that, even a couple times, you can give them a couple times, and then set the timer for 3 minutes. And then when that timer goes off, you ask them. And I would literally set a timer because you want to give the patient the benefit of the doubt, and you'll most likely lose track during the interview of other things. Insight is how well they understand their illness. So if they're depressed and they know it, their insight's actually really good. Judgment, though, is how they behave in light of their illness. So if they're like, I'm super depressed, I know it, but I'm still not eating anything, well, that means they have poor judgment but pretty good insight. Because good judgment is, even though I'm depressed, I still eat, right? I know I need to, even though the food tastes terrible. Bad judgment is, I'm not eating regardless. So we'll go through each of these in turn and kind of see how they're documented. First, I just wanted to show you a variety of different clocks. This actually gives us a lot of information. It's a very handy test that doesn't take a lot of time. This is kind of going in order of severity. So here is a clock set to 11:10. So what I'm looking for is, do they have a good circle? So yeah, their circle's closed. Well, this is a printed circle, so it looks like all of those. In reality, they should be drawing that. And then how's the number spacing? And if you're watching them while they're drawing this, you can actually get a lot of information. They should go from 12 to 6 to 3 to 9, because then they have kind of the template or the rubric in place. And then they can go, after they put in the other numbers, then they can set the clock to 11:10. The shorthand should be at 11 and the longhand should be at 10. If their spacing is weird, like in this case, I would say appropriate circle, poor spacing. And then I would say hands are appropriate with the shorthand pointing to the 11 and the longhand pointing to the 2. In this case, this clock is actually almost evidence of, let's say, micrographia. So maybe you've caught Parkinson's disease a little bit through this. And then, of course, you'd be looking for motor movements like a resting tremor on your mental status exam. Because that looks like micrographia to me. Everything looks actually like it's spaced okay. I mean, the spacing's poor because it's all crammed together. So I would probably say that. But everything else looks okay. Here's an example of the hands being poor. This is also an example of the hands being poor up here, because each of the hands look about the same length, and you really want the minute hand to be the longer one. You can see how bad these clocks can get, where they're not even making numbers, they're making these strange symbols at the bottom, and that happens in Alzheimer's or late. This can also catch like hemi-neglect. So here they put all their numbers on one side of the clock, the same with this. And that can happen with after certain strokes with like hemisphere neglect. So you might even be able to catch some of these other neurological conditions using this as well. Let's practice the mental status exam using these things on this gentleman here. So he's alert and oriented time 4, clock drawing with appropriate circle, number, spacing, and placement, hand and length position, and he's able to perform serial 7s. His memory is 3 out of 3 for immediate and delayed recall. His insight is fair to good, and his judgment is fair to good. I only had the good example in this case, you can imagine, it's very easy using this template now to imagine it less. You could say alert and oriented times 2, memory 2 out of 3, insight poor, judgment poor. So that's the opposite way you could document it. And now that concludes actually the second part. So we've done the subjective, objective. Now we move into assessment and plan. I just combine these together. And this is even going to be shorter than the last section. So we're really coming home here. So for the assessment, there's a couple ways of doing it. One is just kind of bullet pointing your assessments. And then the other is by trying to organize it all into a paragraph. And ultimately, I think the paragraph shows more data. It gives your thought process. It's probably actually the most important part of the note. But a lot of the times, due to time constraints, it makes it difficult. But here's an example of an assessment that I just recently did so that you can kind of get a feel of how this would be written. I think there's still ways that this could be improved, but I just use it as an example. It's a 38-year-old female with a history of Roux-en-Y gastric bypass, GI bleed with chronic ulcers. She states one of her physicians has considered removing her stomach due to the chronic nature of the bleed. Family history of severe substance use, antisocial traits in her father, 15 years in jail for killing a police officer, police dog, as well as her maternal grandfather, physical abuse from stepfather, history of domestic violence, 10 plus arrests for this, no prior psychiatric hospitalizations, chronic suicidal ideation since teen years, 3 prior suicide attempts, overdose cutting, last in her early 30s, so that gives me a kind of a somewhat suicide risk there, because I know it's been at least 18 years since she's done anything to harm herself. Multiple sclerosis, and then evidence of that, I actually saw saw the report, so I was able to write that there was an MRI spine in 2013 showing enhancing lesions. Current smoker of both cigarettes and marijuana, who presents with depression and anxiety within the context of severe interpersonal turbulence. So this is essentially an ID statement that gives me a brief snapshot of everything that's happening in the patient's life in a paragraph. So you start with the age, and then you start with their medical or psychiatric conditions, and then I give evidence for why I'm thinking what I'm thinking. And this evidence is quasi-objective. It's, self-report, but, the fact that she suffered physical abuse from her stepfather and has a history of domestic violence with 10 plus arrests for domestic violence is significant and something that I would like to know sooner rather than later. That she has even the pertinent negatives, that she has no prior psychiatric hospitalizations, but has thought of suicide since her teen years with 3 prior attempts, with the last one being this. So I'm trying to include as much relevant information here. So age, relevant information with support, and then within the context of severe interpersonal turbulence. Sometimes it can be, within the context of recent death or health issues or loss of her husband. So I could have been more specific here, but it at least gives me kind of a brief sketch of what's going on and really what puts her at risk at this time. Then after this ID statement, you can write your working diagnosis. So I think she has currently diagnosing this patient with major depressive disorder, severe recurrent, as evidenced by her PHQ-9 score of 22. Her Xanarini is 10 out of 10. She's predisposed to this because she has a significant family history of substance use, jail, and then her own personal abuse history. Also, other support for my working diagnosis is she's had chronic suicidal ideation since teens, cutting, 3 suicide attempts. And then current relational distress is likely being perpetuated by their substance use, her chronic medical conditions, and then the fact that she's on disability and not working. So I've tried to include not only the diagnosis but support for it, including provoking and palliative factors, perpetuating factors, the onset, how it kind of began, and then any predisposing factors, reasons why this happened in the first place, and kind of what set her up for this. Then we can move into plan. So that's all I really have for assessment. Use an ID statement, use a working diagnosis. It's appropriate just to say MDD severe recurrent. It's better if you include why, so that other healthcare professionals can know why you thought this. For plan, this is just how I was taught: TTFP, test, treatment, follow up, and patient education. So what kind of stuff can I do for this person? Well, for tests, here's all our options. You can do psychiatric scales. Those qualify as tests, like a PHQ-9 or a GAD-7 or a Xanarini. Imaging, like a CT or an MRI, or with or without contrast. Labs, CBC, CMP, etc. An EEG, measuring for seizures or diffuse wave slowing, which happens in delirium. And then sleep study or other specialty referrals, depending on what you think they need. Treatment, in psychiatry, the way I kind of break it down is you can choose meds, you can choose therapy, you can choose both. And then, of course, level of care. Is this an appropriate setting for them? Should they go to a higher setting? Do they need residential? Do they need partial? Do they need intensive outpatient? Or is just regular outpatient okay? Follow-up depends on the severity of illness. And then patient education, you always really want to document that you've went over the major side effects that are possible. I would also include safety planning in the plan as well. And in psychiatry, you always want a suicide risk assessment, and that you've at least discussed possible resources for suicide. It's helpful. Here's an example plan. You have the patient with major depressive disorder, severe recurrent. I put that diagnosis, and then underneath that diagnosis, I put all the things that I'm going to address. And this is their first diagnosis that I put in the plan because it's the most important. It's the reason why they're here. I put a little evidence. So this is, if you didn't want the long assessment, you could also just do a plan with evidence for why this is the case. So they're on disability for medical illness with ex-boyfriend as caretaker. You can continue the Paxil 50 milligrams for now, but we can consider switching to another SSRI due to side effect profile, as well as an inability to monitor because they have that Roux-en-Y, they have a short gut, and we can't get levels with Paxil. We could get levels if we switch to Prozac, or even Zoloft has a level as well. But presently, we'll keep this medicine because the patient feels like it's effective. They're non-compliant on the Wellbutrin. I could have said here whether we plan to stop it or not. I think I just didn't want to touch it, and I wanted to optimize the other meds first, so I just didn't even mention it. But I wanted to remember that they're not taking it. Carbamazepine 200 BID for chronic pain and mood. I didn't include this, but this is something you can get a level on, so it would probably been good if I had said to order a level, because that's helpful again with that gut. Xanarini 10 out of 10, so this patient meets criteria for borderline personality disorder. Recommend putting all current and past meds on a list. We told her to do that because she had all these pills. Like, she basically said, I just have a bucket of pills lying around. Recommend therapy. Patient would like to meet weekly with psychiatry. We'll refer to a Department of Behavioral Health clinic, as Sachs Clinic does not offer weekly psychiatry sessions. So again, this is if you don't have resources at your place that would benefit the patient, you need to help connect them with resources that they need. Then also recommend pill organizer, but she prefers her bucket. So I said she prefers her current system. So you want to say whenever patients disagree with you here too, because that will help medical liability, because if she loses her pills or takes a whole bunch and she says it's because I didn't keep them organized, I now have documented that I told her to organize them and she just chose not to. Then you want to organize your other assessments and plans based on their order of importance. So in order of importance, I thought the multiple sclerosis was next because of the disability that was caused by, in addition to gastric ulcers, because she's on an SSRI, which can cause gastric bleeding. So just continue to follow up with neurology and GI. Marijuana use, we didn't have time to discuss her readiness and goals, so we'll do some motivational interviewing if we see her again. But at present, her use is very small with less than 1 joint a day. So that tells me this is just a use. This doesn't meet criteria for a use disorder. It doesn't affect her functioning. It was just a note for me to remind myself of that. Gastric bypass in 2012, she lost 150 pounds within a year. So that could have hurt her brain. That's why I put it. Whenever you lose weight that much, that can actually kind of be like a TBI. She currently weighs 190 pounds, and we can consider labs, particularly like those vitamins, right? B12, folate. If she doesn't have any on file, she should definitely get those fairly regularly, just to make sure, iron as well, to make sure that that stuff's just not passing through. So then that completes this presentation. Here's some of the references. Again, it's really like the regular SOAP note, but then there's some bells and whistles. And I just want to thank you for your time.